Yeah, so for those who have missed this presentation on August 7, this is nice because I'm repeating the same thing. Okay, so as you understand, remembering that to perform the onconomics, they have to isolate the malignant cells with negative selection to determine the true CTC number, and then basically in order to have the highest accuracy of this results. To simulate the cancer cells environment, we need to have the diagnosis as close to this, as specific as possible to this patient's cancer. So sometimes it's not available. Let's say if a person doesn't have tissue biopsy, then you would have to if the oncotrace test does not determine a possible source, like say if it doesn't show MUC1, which is breast associated with breast cancer, or PSMA, which is associated with the prostate, then you have nothing to go by when you order the Onconomics. It would be cancer of unknown primary. So that changes the growth media, the hydrogel growth media use, and also not use the appropriate growth factors. So that is why it's important to have a cancer type diagnosis if possible. So otherwise cancer of unknown primary, or CUP, will be enough to for the lab to determine the best hydrogel. All right, so what the lab does is they have to isolate, cultivate, perform viability assays. And so there are two types of testing going on. There's the viability assay, which is the chemosensitivity testing, and then there's the transcriptomic microarray, which are the molecular techniques to determine gene expression profile. So I like to look at this as a two-tier system, because one gives you the actual results of the testing, which is after the fact, as it were, because you're testing the cancer cells against the anti-cancer agent ex vivo. And so when the results are out and it shows high cell death rates, let's say for the cytotoxic agents, now you're going to see a percentage expressed as the cell death rate. And so that's pretty straightforward. It is there. The target was there, and the drug was able to, or the drug or the natural substance was able to destroy the cancer cells at a certain percentage. Whereas when you do a transcriptomic microarrays, you're looking at druggable targets. Hopefully there is one, but you don't know for sure. It's an assumption. And this is where a lot of the conventional are doing when they do a DNA study. They're looking at, for variants from the mutation, they're looking at variants for target. So they're looking for druggable targets. And so to determine that, we need to know the gene profile, and the gene expression profile has to, you have to destroy the CTCs, because these are all tested on the CTCs. So you destroy the CTCs and isolate the mRNA, performing a QC to make sure that the mRNA is good quality. And then they do a reverse transcription to see complementary DNA from mRNA, and they do a hybridization of the complementary DNA in order to determine the gene expression using these microarrays. And so once the gene expression is determined for the tumor-related genes, there's over 90 genes, then it's now shown as a percentage in the report of overexpression or downregulation. And analyzing the data, they analyze the data to see if it is repeatable. And so it is also done with a qPCR for confirmation. So it is a very good gene profile. And the gene expression profile gives you two major information. One is what could be a druggable target. The second is what gene or groups of gene are driving the disease potentially most influential. And that, of course, is determined by how much percentage expression that overexpressed gene is showing. So the higher the gene expression, the more overexpressed, the more likely that then that's probably has a lot more influence in cancer proliferation. And the goal is, of course, is to block this gene from overexpressing or down-regulating them with an agent. Now, this is a review. When you're looking at how the protein synthesis occurs, it all starts out from the DNA transcribing into the RNA, and then from the RNA translating into peptides, which are now being synthesized as a protein. And when there is a protein, then there's a target, right? Most therapies worldwide target the proteins rather than DNA or biomolecules in terms of treatment. Now, gene expression refers to the mRNA. For RGCC, we are testing the mRNA, and it's better than just DNA test because the DNA mutations, you have to, you basically are looking at a further upstream here before going downstream. We're much closer to where the rubber hits the road because we are just mRNA and then protein synthesis. So when we're doing a reverse transcription, we're actually looking at the mRNA because gene expression leads to protein production, but not always. Keep that in mind. In the conventional oncology world, they are assuming that there's going to be a protein production due to the mutated genes. Okay, so that's why it's not as direct as the chemosensitivity test, which is what the first tier is. The chemosensitivity testing results outweighs or takes precedence over gene expression profile. So now you're looking at a expression now, and as I mentioned to you, there's so much information in the gene expression because it can also tell you what additional layer of treatment customization or personalization you can do. Because in the chemosensitivity test, there's only 171 plus agents routinely tested. The rest that are anti-cancer in the inventory are not. So you could order additional testing to increase that, right? So increase their options. So the gene expression gives you a combination of what's been tested and that's not part of the routine testing that you could still use. And so that's why it's an additional layering on top of the chemosensitivity agents that you selected. So it broadens your choices of treatment options based on what genes you want to target. And the more genes that you target that are overexpressed, the more likely that you'll get even much better outcome than just the chemosensitivity test results that you're using to create a treatment protocol. So just keep in mind, the reason that we've got the gene expression profile is it increases your scope of what you can use and what you can target. Now, if you have just the chemosensitivity test results and you don't have the gene expression, yes, you can use the chemosensitivity, but there's not enough to broaden your scope because you don't know what other genes you could be working on to block, to downregulate, to alter the metabolic pathways. So these are all important. That gives even more options for the RGCC practitioner to choose from. So having both information, chemosensitivity and gene profile, will give us the maximum options to address the cancer. So the gene expression, as I mentioned, can also tell you which is the main driving force of the disease based on the genes having the highest activity or overexpression, and that you could use to target more so and get even potentially better outcomes. It also gives us the insight on the hormone receptor and HER2 status, because sometimes when a patient comes to you with breast cancer, they may not have the information on the hormone status, receptor status, but you can look it up when you get the results of the Onconomics plus the progesterone receptor and the estrogen receptor status are already shown. If they're both expressed, then that means it's hormone positive if they're both overexpressed. And then, of course, the HER2, that's coming from the CERB2, the CERB2. And if you see that gene overexpressed, then you've got triple positive breast cancer. So that's what's nice about this. It can confirm the hormone status of the circulating tumor cells. Now, what's interesting is sometimes the hormone receptor status of the tissue biopsy does not reflect the same as the CTC receptor status, which is kind of interesting. That tells us there's more than one population. There's several subpopulations that are different. That's why they're heterogeneous. So the ones in the tissue could be HER2 negative, whereas the CTCs that are tested are HER2 positive, or vice versa, which is kind of interesting. And so that's why you got to keep your mind open, that it's not necessarily one population we're dealing with. There may be several. So that's what's helpful about this. It can give you more information than just tissue biopsy. There could be other subpopulation that may or may not have the hormone receptors expressed, and still that could give you additional customization of therapy. Remember, the ones in circulation are the future metastases. The ones in the tissue may have its own self-limitation out there, and there's not much they can do. But in order to metastasize, it's got to spread, and the hematogenous spread is going to be the one that you will be detecting because of the CTCs that we detect. Now, also, the CTC sensitivity to damaging effects of radiotherapy and hyperthermia is shown on the heat shock proteins. So whenever they're downregulated, minus 15% or more, especially, these cancer cells are very sensitive to heat damage, and they're not able to repair it. So it's very important to consider using this therapeutic option if they're highly downregulated. That means the negative number is fairly high, like minus 30, minus 40. Those can be very much useful in addressing the cancer, because it can shrink the tumor fairly quickly when you have a very high downregulated heat shock proteins. Now, if the heat shock proteins are 0% or overexpressed, then it's pointless to try to destroy these cells with hyperthermia or radiotherapy, because they're resistant. They'll just like the healthy cells then. And of course, if they're overexpressed, then they're harder to destroy by radiation or hyperthermia. So it's always the downregulation that you want to see to help include that option as potential therapy approach. Now, it's always important to keep it in mind that when you're doing the gene expression profile, you're basically addressing growth factors, signal transduction pathways, angiogenesis, metastasis, cell cycle regulation. So all this information here, particularly the first four, growth factors, signaling, angiogenesis, metastasis, these are all going to be addressed in the class 3 natural substances, especially the growth factor, signaling, and angiogenesis, and the class 3 agents are the ones that block these pathways, and so these are the major ones that are controlling the growth that you could do something about. Okay, there's not as many that you can do about with the metastasis. Yes, you could look at the MMP and look at the biomarkers reference guide to see there's something natural that can downregulate the MMP gene, and then of course the P27, P16, and P53 for the cell cycle. There may be a few that you can do to downregulate and overexpress P53 or P16, but the major ones are really the first 3. And then the EpCAM positive subpopulation is also shown in the Onconomics test. And you can go down all the way to the last page of the gene profile, and you can find the EpCAM positive subpopulation CTCs and just subpopulation cells in the table. Not on the graph, but it's in a table. That's where you can find the numbers, like 1.5 cells per 7.5 mils or 2.1 cells per mil. That is on the table, and so you can pick that out. For those who don't do the OncoTrace or OncoTrail as the baseline, you'll see the CTC number, but then to locate the subpopulation for solid tumors, you've got to go to the last page of the gene expression and locate the EpCAM on the table, and you will see the numbers associated with that in terms of their concentration. Okay, so really the clinically relevant genes are the ones that are overexpressed. Now, what's interesting and very can be confusing is that these gene expression, especially when they are in groups, categorized in groups of genes that kind of work together, some may downregulate, and the other ones will overexpress, and it can just switch. And so this is where it's very important to make sure these patients are not on any treatment at the time you draw the blood, because if a person is taking a chemo agent, a chemo drug, and this drug is particularly or a targeted drug to get an example here is let's say this targeted drug is downregulating the VEGF, which is a dominant angiogenesis gene. So let's say that the VEGF is 55% overexpressed, and they're taking a VEGF inhibitor, a VEGF receptor inhibitor, like Avastin or bevacizumab. What happens is that you get the blood drawn, and so these cancer cell genes are smart in that because of that exposure to the drug, they're gonna be finding other pathways, and so that gene expression may be lower than normal, and there's another pathway, gene pathway that's showing an overexpression. So it's not the true actual expression if the person wasn't taking the drug itself. So that's why you have to bring this patient's blood into equilibrium by discontinuing that agent for 14 days. That's our guidelines. So if you stop the drug for 14 days prior to the blood draw, then the actual gene expression is going to be much more accurate. So you have to keep that in mind. It can change as genes are always mutating and changing. And so you need to make sure that your test results are accurate. Now, you can't downregulate all the genes, but as many as you can will make your therapy outcome much more favorable. You can't do anything really with the downregulated genes, because if you try to upregulate them, that could affect other genes. So you don't try to upregulate the downregulated genes. We just don't do that. We only work on overexpressed genes to block it or to try to get it downregulated. And of course, if you are aware of the tumor microenvironment that controls the genes or influence the gene expression over time, changing that environment, like lifestyle, diet, and so forth, it will eventually downregulate cancer genes, but it takes a long time. So having this information and using a drug or an agent to downregulate the genes would kind of significantly improve the outcome faster, because the natural approaches can take a long time. Now, the resistance factors are kind of interesting because you have to, most of our practitioners might have a little trouble trying to utilize this information, because multi-drug resistance 1, MDR1, MRP, LRP, all these are really different parts of the same thing that the cancer is trying to do here, which is they're trying to resist treatment. And the way they do that is they have a pump that effluxes the toxic agents that's targeting them. And so they have that ability to efflux more than the usual. So that's how they can escape being destroyed. And so if you have a high MDR1 or high multi-drug resistance, you are not going to easily destroy the cancer, because there are high resistance factors. And so you need to use a ABCG2 pump inhibitor, and that will help to decrease the MDR1 and MRP and LRP if there's an elevated LRP, to allow the cytotoxic agents or anything that's destroying the cancer to do the job with less resistance, that they are now easier to destroy. And this is where the oncologist doesn't have the information. So, they just go from one drug to the next drug if something doesn't work. But you can make it work better by lowering the resistance using agents that are known to do that. And usually the flavonoids is what is a good approach from the holistic side. There are drugs that can do that, but the flavonoids such as quercetin, maybe berberine, curcumin, ginger, berries. There's all kinds of flavonoids that you can apply daily, have the patient take daily to improve the effectiveness of cytotoxic agents, and that way you'll have much better outcome. The GST is the glutathione transferase. That's the detox pathway phase 2 or deactivation, and so when the GST is high, the cancer cells can eliminate much more effectively, or much more so than a normal cell. And so if you have a high GST, you certainly don't want to support more elimination, and so you have to be cautious about the use of whether you think a glutathione support is necessary or not, because when you have a high glutathione S transferase, adding more glutathione may not necessarily lead to a favorable outcome, as that could fuel more detoxification due to the increased GST. So you have to be cautious. I mean, there are some debate as to whether more glutathione can be beneficial, but make sure that you're actually seeing good outcomes and the drop in CTC. If it's not dropping, then you need to change your approach.
Can I ask
The
what
yes,
about
go ahead.
a coffee enema that increases? I mean, obviously, it's doing a lot of detoxification and removal of waste, but it is supposed to increase your glutathione levels. Would you
Yeah.
not do that for someone who has this?
Yeah, you know what's interesting is that I know about that because I am a Gerson practitioner, so we have protocols for coffee enemas, and some patients are doing 5 coffee enemas a day. You kind of wonder about that. How come they seem to be doing quite well? Now, of course, it's hit and miss because it's not a specific personalized program like this. And so I think Dr. Gerson knew something about the glutathione, but he did not specifically state it in this way. But they do it about every 5 hours. So I think that that if it's spaced far enough from the agent that you're using, I think that would probably be okay. It's just that you have to consider the half-life and determine, is there enough time to when it's the right time to do a coffee enema. Generally, I have patients do, one in my own practice is 1 coffee enema per day, early in the morning, several hours before they start their RGCC protocol.
Right.
So that's what I would do is I wouldn't do it at the same time with the protocol because that could increase the GST, which it does, in fact, and that might put all these agents to waste. That's why we don't do coffee enemas on the day of chemo treatments because that is not going to be a good approach. We have to wait a few days before they restart the chemo, before they restart coffee enemas. Is we usually wait 3 to 4 days after the chemo infusion. Okay.
Thank you.
So here are some of the information you could look up. Very deep information about multi-drug resistant MDR1, the MRP, lung resistant protein, and GST. So you want to read more about that. That would be helpful because it does help select and narrow down which drugs or agents you shouldn't be using due to these high resistance factors. Now, the reason that it's nice to have information put down on a spreadsheet when you're doing all these onconomics, and you can see this is several onconomics right here doing gene expression that I put down in my spreadsheet. It's because you could see what's been changing over time in the gene profile. And I know these are very small numbers, but the bottom line is you will see that over time, usually the cancer genes are going to be decreasing in their expression to closer towards normal. And that's because a patient's lifestyle has changed, their diet has changed, they're not favor cancer. Like, for example, you're on a high carb diet versus a low carb, that could influence the growth and of course the IGF receptors 1 and 2. You're going to be seeing that over time change, and the goal is to drop that down and not high expression. So it's good to track the changes, and then you'll also see the changes in the sensitivity of the agents over time. And some agents, they become less sensitive, and then other times they become more sensitive. So you will always have this cycle, and that's why by doing the Onconomics Plus every 9 to 12 months or Onconomics Extracts Plus, not only can you track the gene changes, which can help you determine which gene is more dominating now than before, but you also see what agents are becoming less sensitive so that you can change your protocol and create new ones that are more relevant for the current status. And that will keep your CTCs coming down steadily over time to reach your remission level, which is the goal. And that needs to be, 1.4 or less, or even 1.2 or less. But the lower and closer to zero, the more lower and very low risk for any future disease activity. And so that should match the imaging once you're down at that lower level. Anything above 2, they typically don't really match. Sometimes they do, sometimes they don't. But once you're down into the low ones on the CTC number, then they start to correlate with imaging and clinical imaging. Okay, so that's pretty much the information on this discussion. And now I'm just open to anything else that you have a question of, because in our August 7 meeting, there were like 20 some of you out here, and many of you have questions, and so we had time to answer that. But now we have only a couple of you or so, and so let's have if you want to present something that you have seen or you already tested some things and you have questions, I'll be happy to help you out, or we can discuss it, because that's helping us learn more.
I have
So
a
are
question.
there anything?
I do have a question. Sorry, I'm
Go
also
ahead.
in the sauna, so that's why I don't have my camera on.
Oh, no. Very
Killing
good.
two
I like
birds
that.
with one stone. So with the immersion of QT scan for the breast, what are you guys seeing? But because before, with these low CTC counts, it means that the tumor is generally pretty small. And so somebody with a low CTC count, below 2, maybe on mammography or regular ultrasound or even an MRI, it wouldn't show up. I guess now that I don't know how familiar you are with QT scan, and I don't think it's been around that long to be able to probably have lots of data yet. But I mean, if somebody's done that, if they have some CTCs, less than 2, and it's coming from the breast, but the QT scan, even that they've had serial ones and they're not seeing any changes, in fact, maybe even seeing improvements, I guess, how does that correlate? It's just still too small to be seen, or what?
Yes, they're too small, because as I have a diagram that shows a mass, and then a diagram that shows something else inside the mass. You don't really know, you can't quantitate, and they're not the same. The methodologies are totally different, and so you can't really equate. When you look at a CTC number, that's you shouldn't equate that to how much cancer is in the tissue, because that could be misleading, because if a person has been having treatment, there may still be a lot of residual disease, but they're not releasing the CTCs anymore because they're becoming inactive, but a scan might still show quite a bit out there. Just like, when you're doing a bone scintigraphy of the full body, you're going to see a lot of areas that had bone metastasis, and there's some sclerosis, there's some that are still showing a bone that's damaged, but when you actually do the CTC count, it's really low. So they don't. They're all accurate tests in their own way, but you have to interpret them, and it has to be making sense, and this is the challenge. Not one is going to be 100%. So that's why it's good to have more test results to give you a much more accurate picture. That's the best I can say.
Yeah, I mean, I'm more talking about the opposite. Like somebody does it as a screening tool, has CTCs, gets all kinds of imaging, and even on something sensitive like a QT scan is literally finding nothing. What it's just tumors too small.
Because it's too small. It's below the level of detection that we are at. And so we're seeing activity while they're not seeing it from their scans. And so that's why we need to know the risk. Okay, so if we're seeing cancer cells, does it mean anything? Does it mean that this is serious stuff? Should this be treated? Well, we don't know that until we assess the cancer stem cells. And the only way to assess the cancer stem cell status is by ordering the OncoTrace or OncoTrail. Right. If you do the OncoCount, if you do the Onconomics Plus, you won't have that information. So we need to first determine, okay, is this a high risk? Is this a low risk? Is it no risk? And to understand that, you have to have the phenotype markers and the cancer stem cell or stem cell markers. And now you can determine if the risk is high enough or low enough to just maybe just continuous surveillance. These cancer cells may never become a tumor. It may just be very small enough that they can't be visible for many, many years. We don't know. But when it does happen, sometimes they suddenly go to stage 4 because they're already in many areas. They were just not visible enough. But if you knew ahead of time how aggressive these cancer cells are, then the subpopulation, which is the cancer stem cells, you could be ahead of the game that you knew it would happen. And so by monitoring this on a periodic basis, if you start seeing the count starting to increase, you need to start acting on it because before they become a problem and become visible and detected early on. So yes, early detection of activity and treating it before it becomes a problem that oncology has to work on. And that's the best, is because you can use more holistic approaches because there's still no option from the oncology since there's nothing to be seen. I hope that helps.
Yeah, I mean, I don't know who would get a CTC count and have it positive and not act on it, at least with supplements. I mean, that seems a little
yes,
nuts,
at least with supplements.
but yes, right. Okay, thank you.
Sure. So that is the roundtable. Again, depending on how many people we have. In the previous times, we have 20 and 30s, but this is only the third session. So because of the request on the recording, I brought up that we better repeat this one more time because we missed recording the first time on this session 3. So now it's accessible, and our branch will put it into YouTube so that more people can watch this section 3 or session 3 deep dive. Okay, so are there anything else that you would like to ask? Is there any other question? Or if we're not having any more questions, we are done.
Can I just ask you a personal question at the very end?
Sure, Dr. Myers.
Thank you. I appreciate it.
Alrighty. Well, thank you, Dr.
Okay.
Denot. I'll go ahead and upload this and I'll stop the recording so you can ask your personal question. I'm going to hop out as well. Thank you very much.
Okay.
You're very welcome.